Everyone, welcome to today's review. Our topic for today is lung anatomy and physiology. Let's begin. So, progress. High yield. You need to know the development of the lungs from the embryonic period up to the postnatal period. There are different stages. 1. Embryonic. 2. Pseudoglandular. 3. Canalicular. 4. Saccular. 5. Alveolar. If you look at this period, I have a question. Surfactant develops at week 20. So if a baby was born and the development is in the pseudoglandular period, do you think the baby can survive? Yes or no?
No.
No. Why?
See, that even if you were to administer like steroids or anything like that to promote surfactant production, the establishment, I think, of the appropriate cells haven't been made. So you're not going to have fetal viability, even if you had early birth.
Excellent. Good job. So anything below like pseudoglandular period and embryonic period, incompatible with life. Canalicular period is the period where the surfactant starts at week 20. It actually fully develops in week 25 during the saccular period. Okay, so those are high yield. There's a summary on the next slide. So embryonic, from lung bud, you can develop the trachea, then the bronchial buds, mainstem bronchi, the lower bronchi, and your segmental bronchi. Errors at this stage can lead to TEF, tracheoesophageal fistula. Question, what is TEF? And how are we going to diagnose someone who has TEF? Anyone?
You could do an put a scope through to see if they have that, or typically if you have some kind of a atresia, the baby would present with poor feeding ability and potentially vomiting due to like them not having like a proper tract going all the way to the stomach.
Good job. So fistula, abnormal communication between two organs. In this case, your trachea and your esophagus. So if you pass an NG tube, it doesn't completely go through the stomach. Okay, that's another way that they can put in the vignette. Pseudoglandular stage, respiration impossible. So this is incompatible with life. Canalicular, this is where your respiration capable at 25 weeks. Why? Remember the surfactant, it develops 21. It fully matures on the 25th week. Saccular, it's just the development of your bronchial tree. From alveolar ducts, you have the terminal sacs. The last stage is the alveolar stage, from terminal sacs to adult alveolar. Remember, it develops. The surfactant still develops up until you grow. Okay, so by 8 years old, you have more than 400 million alveoli. I yield again lung development, know the stages, know what happens on each stage, what develops on each stage, and some of the pathophysiology of each. Okay, embryonic, think lung bud going to tertiary segmental bronchi, pathophys, tracheoesophageal fistula. Pseudoglandular, respiration impossible. It's incompatible with life. Canalicular, from your terminal bronchioles, you're developing your alveolar ducts. This is where respiration is capable at 25 weeks. Why? Your type 2 pneumocytes are developing. They are the one who gives you your surfactant. Saccular, the alveolar ducts, the terminal sacs develop. And the last one is alveolar, where the terminal sacs develop into your full-fledged adult alveoli. Okay? So this is a nice picture of your respiratory tract. You have the thyroid cartilage, you have the trachea, apex, left lung, and right lung. Now, question, differentiate to me your left lung from your right lung based on this image. Just surface anatomy.
Horizontal fissure.
So where can you find the horizontal fissure and oblique fissure? What part of the lung? We have two fissures. The right side, okay? Look, the right side has two fissures, horizontal fissure and the oblique fissure. How many lobes do you have on the right lung?
3.
3 lobes. On the left lung, you have two. Why do you only have two lobes on the left?
So that you have a room for your heart.
Excellent. What's the homologue of the middle lobe on your left lung? There's a part there that's supposed to develop as the middle lobe, but it didn't develop on the left side of the lung. Why? What do you call that? It's a homologue.
The lingula?
Excellent. The lingula. So see here, you have two lobes on the left. Why? The cardiac is here. Your heart is there, so only two lobes. Only one fissure on the left, oblique fissure. On the right, you have two fissures, horizontal fissure and an oblique fissure. Two lobes on the left, three lobes on the right. In terms of the bronchus, compare and contrast to me the difference between your left primary bronchus and the right primary bronchus. Which one is straighter? And is there a significance? What's the significance of that? Anyone?
The right main bronchus is more vertical. It's shorter.
Excellent, excellent. So in terms of aspiration, where do you think the aspirated material will go through? The left or the right?
The right.
Excellent, the right. So when you're standing, you aspirate, you choke on chicken wings, right at the bone, it'll probably go to your right lower lobe. However, if you're lying down, where does it go? You aspirated the foreign material. When you're lying down, where does it go? Of course, the right lung, but what lobe in the right lung? Anyone?
Like the middle lobe?
Middle lobe, excellent. The right middle lobe. So high yield, foreign body. Aspiration, when you're standing up, right lower lobe. When you're lying down, it goes through your right middle lobe. All right, so this is another good section, right? A cross section from the trachea. We'll look at your bronchial tree there, your tertiary bronchi. There you go. And then we zoom in, the alveoli, and we see the structure of alveolar walls. Very simple. Simple squamous epithelium. You also have your cells there. You have your Kupper cells. You have your different kind of cells. You have your capillaries. All right, let's do gross anatomy. So the respiratory tract consists of two zones, conducting, respiratory zone. What's the difference between the two in terms of functionality?
You don't have gas exchange at the conducting zone. Its primary function is just to kind of act as not only as a barrier, but as to warm up the air that's coming into the lungs. Make sure you remove like any debris and things using your nasal cavity and a couple of other functions that I can't remember.
Good job, excellent. So my man is correct, right? So we have conducting zone. This is non-respiratory tissue, no gas exchange. Respiratory zone is the lung parenchyma, the site of oxygen and CO2 exchange. Different locations, upper respiratory tract, nasopharynx, larynx, the lower, from the trachea, bronchi, bronchioles to your lungs. What's the function of the respiratory system? Ventilation, respiration, gas exchange, immune defense, right? You have your cells there, your cellular clearance, you have alveolar macrophages, and some goblet cells. So there's another picture, right? What level is the tracheal bifurcation? Carina. What level is this?
T4, T5.
Excellent, T4. So this is your tracheal bifurcation. So you can see the right one is straighter, right? And narrower. So most of the foreign body that's aspirated will go to your right lungs. So large airways. You have nasopharynx, larynx, trachea. Trachea, it's a series of cartilages joined together by what? High yield annular ligaments. It bifurcates at the level of what? T4, and then to your left and right main bronchus. This is your carina. Are there any neighboring structures? Yes. Posteriorly, you have the esophagus. You have the descending aorta. Anteriorly, you have the thyroid, ascending aorta, brachiocephalic trunk, and the superior vena cava. And then the left and right, your main primary bronchus, they divide into secondary bronchi or lobar bronchi, and then the lobar bronchi further divides into segmental bronchi or your tertiary bronchi, and then you have the bronchioles, and then the last is the terminal bronchioles. Don't forget, high yield airway resistance is lowest in the small airways. Why? Due to the large number of parallel bronchioles, while the highest airway resistance is where? In the larger airways, your trachea and your bronchi. Okay, don't forget that. So what's the function? Conduction of air. Anatomic dead space, right? There's no gas exchange in your conducting zone. Warms and humidifies air. High yield mucociliary clearance. You can find ciliated epithelium there that transport mucus. They have cilia. It transports mucus, bacteria, and dust towards the throat, whether it is either swallowed or expelled through the mouth. Another good image of the lung. Another X-ray image. See this one, the lingula. The lingula is the homologue of the middle lobe. Don't forget that. Okay, lingula, homologue for the middle lobe of the right lung. All right, another high yield. Look at the image here. We're comparing the right hilus from the left hilus. Right? So you cut it horizontally from the hilum, right? So the question is, what's the relationship of the pulmonary artery to the hilum itself? For example, in the right one, right? This is your right primary bronchus here. We cut it there horizontally. So what's the relationship of the pulmonary artery? Is it anterior, superior, inferior, or posterior?
Anterior.
What do you think? Right? Again, please.
Anterior for the right.
Excellent, excellent. So RALS, right is anterior. So this is the hilum, right? Look at this one. Oh, there you go, anterior. How about on the left side?
It's superior for the left.
It's superior on the left side. See this one, the pulmonary artery is superior. Look here, they are anterior. High yield RALS, R-A-L-S, the right. Look, anterior. Look at this, your pulmonary artery is anterior to the hilum itself. On the left side, it is where? Ooh, up there, superior. Pulmonary artery is superior to your left hilum. That's high yield. Again, just to reiterate the foreign body aspiration, most of them, when you are standing, 80% goes to your right lower lobe, 20% goes to the left side. Most of them are in this one. When you're standing, when you're supine, it goes to your right middle lobe. Don't forget that distinction. That's high yield. Read the vignette carefully. Okay, let's go to the lungs. Located in where? Pleural cavity, surrounded by what? We have the visceral pleura. There's a fluid in between the visceral pleura. There's a space there, pleural space, and then you have the parietal pleura here. What's the function of that space? What is in that space? There's a fluid there. Why do we need to have fluid there? In between the visceral pleura and the parietal pleura. The pleural cavity has a fluid. Why?
So you have a smooth expansion and compression of the cavity without any sort of friction.
Okay, excellent. So, is that good or bad? It is good. It's good, right? It provides some space for expansion, but however, you can have pleuritis, inflammation, right? If you have an infection, it can infect that space, potential space. So it's a gateway for infection. Again, lungs, it has the hilum, the point of attachment of the lung to the lung root. You also have some bronchopulmonary segments there, and the lung parenchyma consists of your bronchioles and your alveolar ducts and alveolar sacs that are surrounded by your capillaries for gas exchange. Again, the star here, the differences between the right and the left lung. Don't forget, only the right lung has the middle lobe. Where can you auscultate it? The middle lobe of the right lung. Where is it? Where can you auscultate? Fourth and sixth. All right, fourth and sixth. Where? Anterior at the mid-clavicular line. Don't forget, the right main bronchus is wider, shorter, and more vertical than the left main bronchus, so aspiration foreign bodies and aspiration pneumonia are more likely in the right lung. Another high yield point, each bronchopulmonary segment can be removed without affecting the function of the others. Why? Because you have a lot of bronchopulmonary segments. Vasculature, again, let's go back to your CPR1, blood flow. So deoxygenated blood, tell me where does it go? So SVC, and then IVC, it goes to where?
Right atrium.
Right atrium. What node can we find in between the SVC and IVC?
The SA node.
SA node, specifically where in the right atrium can we find it? In between the crista terminalis and your SVC specifically. What's the function of the SA node?
It's a pacemaker.
It's a pacemaker. How many beats per minute?
60 to 100.
60 to 100 beats per minute. The signal goes to where? From SA node to where?
AV.
The AV node. Does it slow down or no? Does the signal slow down or no? Yes or no? From the SA to AV, is it the same signal or the AV slows it down?
I believe AV slows it down.
Excellent, of course, it slows it down, right? So from AV node, where does it go? From the AV node, where does it go?
To the not the bundles.
Bundle branches, left and right.
Branches.
Okay. Left and right, bundle branches. We call this one Tawara branches, okay? And then, where's the last one?
Purkinje fibers.
Purkinje fibers, excellent. Let's go back to blood. So now we're in the right atrium, and then it goes to what valve? What valve does it go through?
Tricuspid.
Tricuspid valve. If I am an IV drug user and they use heroin on the street, right? The most common cause of endocarditis is the tricuspid valve endocarditis. Don't forget that. That's high yield. So tricuspid valve, then it goes to where? Right ventricle, right? So this is your deoxygenated blood, and then it goes through where? Pulmonary artery. It goes to the lungs. You have the gas exchange, and then?
Okay, so the answer is B, right? When you're standing.
And then pulmonary veins, right? To the left atrium, and then mitral valve, left ventricle, then your aorta. You have different kinds, ascending, descending, thoracic, and abdominal aorta. So good job. Don't forget, the lungs has a dual blood supply, pulmonary circulation and bronchial circulation. Give me an organ that has a dual blood supply. Another organ that has a dual blood supply, aside from the lungs.
Liver.
Excellent, the liver. So you have your portal circulation in the liver, systemic circulation and the portal circulation. Good job. Lymphatic vessel, do I need to know? Well, the nodes are important. So each bronchus has a bronchopulmonary node. You have the tracheobronchial nodes, paratracheal, yada, yada, yada. The most important thing is they all drain to where? Thoracic duct on the left side, high yield. On the right side, it's on the right lymphatic duct. Most of the drainage goes to the thoracic duct, okay? Thoracic duct on the left, right lymphatic duct on the right. How about the innervation? Innervation is middle yield, I think. So parasympathetic fibers from the vagus nerve, they innervate your smooth muscles and glands. So if I have an increase in parasympathetic, increase in vagus nerve stimulation, I can have bronchoconstriction, I can have increase in secretion. Sympathetic fibers, they act on B2 receptors, they innervate blood vessels, smooth muscles and glands. So you have bronchodilation, vasoconstriction, and it decreases secretion. M3 receptors, GI, GQ, GS. M3 receptors, GI, GQ, GS.
GS.
Careful.
Yeah.
Again?
Q.
GQ, excellent. GQ, kick, right? This is your Q. So how are we going to, if I stimulate the GQ receptors, what happens? Tell me what happens. So if I stimulate the GQ receptors, what happens? Hello?
It would be stimulating phospholipase C and then activating PIP2 to
Excellent.
cleave into IP3 and DAG, and then that ultimately leads to increased calcium.
Excellent. Good job. Good job. B2 receptors, GI, GQ, GS.
GS.
Careful. It is GS. I'm just.
Oh my.
Yeah, I'm just testing you, but it's good. It is GS. So what happens? Tell me. Tell me what happens. If I stimulate GS, what happens? Tell me the cascade, the secondary messenger cascade. Anyone? It's like increase in cyclic AMP, right? Increase in. So you have adenylyl cyclase, and then increase in cyclic AMP, and then increase in calcium. This is protein kinase A, increase in pKa. Contrast this one with your GQ, which is all of that PIP2, IP3, DAG, increase in calcium, and protein kinase C, PKC. This might be trivial for you, but when I was in term 2, I had some exam questions like this simple. Okay, so don't forget it. The secondary messenger system. If it's parasympathetic stimulation, you have bronchoconstriction and increase in secretion. If it's sympathetic stimulation, you have bronchodilation, right? And you have a decrease in secretion. Okay, let's do histology. Look at this, a cross-section of the trachea.
Can I ask a question
From the top layer.
the lymph, or the lymph nodes? So I'm wondering, so there was a question where there's a malignant growth at the right main bronchus, and they were asking where it would drain first. I was kind of between, the answer is inferior tracheobronchial, which is at the carina.
At the carina, yes.
But I was wondering, wouldn't it also be the bronchopulmonary node? Because that one is on the main bronchus, I believe. So I was confusing between them.
Between the, like where does it drain?
Yeah, if there's a malignant growth at the right main bronchus, would it go first to the bronchopulmonary or the tracheobronchial node? I don't know if anyone recognizes that question.
Is that from Grace Anatomy? From Grace?
Yeah.
Usually, for lymph nodes, I always go through what node is the closest to the organ that is involved. That's my trick. If it's on the near the carina, then maybe near the bifurcation. So it's in between your trachea and your bronchus, right, left and right, your primary main bronchus, but probably that's why it's in it's tracheobronchial nodes. So the principle that I always go to is which node is closest to the organ that's involved. I think that's, I don't know if it helps you, but that's my thinking. Anyone from the group that knows the question?
May I ask what question number is that?
106, chapter 2.
Question 6?
106.
Oh, 106. Sorry.
Okay, okay. The trick about the Gray's Anatomy is go to the explanation. Okay, so do them when I was in term 1. I think I did them twice. So always go to the explanation and read the explanation carefully. Still gonna recycle some questions based on the explanation. All right, so read the explanation very, very carefully. If you, since you don't have like live anatomy, again, go to YouTube, search Dr. Sanjoy Sanyal. He's a professor at American University of the Caribbean, I think. He's doing dissection, like a live dissection of a cadaver. Or Dr. C Anatomy from Canada. She's also doing a cadaver dissection. Just search them on YouTube, okay? For your lab exam. All right, innervation, again, we have parasympathetic, sympathetic. So let's look at histology. So this is a beautiful image. As you can see, let's go, the layers from top to bottom. Top here, look at this, a plate of beautiful hyaline cartilage. Question, function of hyaline cartilage and other parts of the body. Where can you find hyaline?
You could find cartilage in the trachea.
Excellent, good job. What's the function of hyaline? Elasticity, right? Support, right? In what ossification can we find a cartilage backbone? In what ossification, the process of ossification, can we find cartilage as the backbone? Guys, bone formation.
Hyaline. Hyalin's going to be the scaffold by which you build.
Yes, but what part? What ossification? There are two kinds of ossification. Tell me which part is hyaline, the backbone.
I know it's not endo-ossification, it's the other one.
Membranous?
Endochondral.
Endochondral, yes.
Excellent. So endochondral ossification is the backbone. Membranous ossification, you don't use a cartilage. So if I have a deficiency in endochondral ossification, give me a disease that you already know, that you already discussed.
Achondroplasia.
Excellent. Achondroplasia. They have short limbs, right? They have short stature. However, they have a normal skull. Why? They have a normal size of head, but they have short limbs, short arms. But
because the skull is membranous.
Excellent. The skull it doesn't rely on cartilage, right? Contrast this one to your long bones. Your long bones, they rely on cartilage. That's why in people who has achondroplasia, they have a normal sized head because it's membranous ossification. Other organ is the clavicle. Clavicle is membranous ossification. The rest, your long bones, your endochondral ossification. Good job, guys. So we have hyaline cartilage here, and then we have the perichondrium here. Then we have the lamina propria with elastic fibers, and then last but not the least, you have your respiratory epithelium, and here is your lumen. So this is just a good picture of the trachea. Don't forget hyaline cartilage, right? Again, look at this. The respiratory epithelium here. Look at the apex here, right? Look at this one here. So we have kinocilia at the apical surface. This is the lumen, respiratory epithelium. You have the kinocilia there. Cilia, microtubule or microfilament? Cilia, microtubule, microfilament?
Microtubule.
Excellent. It is microtubule. Give me a disease that you know that has a deficiency in microtubule formation. It can have, you can have situs inversus.
Cartigenous.
Cartigenous syndrome or primary ciliary dyskinesia. Contrast the infertility in cartigenous with the one in cystic fibrosis. contrast the infertility that is experienced by your patient who has cartilaginous and the one who has cystic fibrosis. What's the difference?
I think in cystic fibrosis, only the men are infertile.
Why? Why? No?
Because the cilia isn't like propelling the sperm.
Cystic fibrosis. This is for pathophys. I think absence of vas deferens. That's why they're infertile. Men who have cystic fibrosis, it's just, it doesn't develop. The vas deferens doesn't develop. And you need that to conduct the sperm from the ejaculatory duct. Right? You need the vas deferens to go to the urethra, and then. But in primary ciliary dyskinesia, cartilaginous, what's the problem? There's no flagella. Right? The sperm needs a flagella. There's no development of the flagella. That's why they are infertile. Okay, that's it. That's basically it. More of these diseases you're gonna learn next term, term 4, for your pathology. So again, look at the respiratory epithelium. They're beautiful here. The apical surface, you have the chynocelia. Remember the mucociliary clearance, right? For debris, for bacteria, you need to cup it out. This is another good image. I like histology. Don't forget, do the questions from your Lippincott histology. We have a lot of questions there. Do them. Okay. Another chynocelia there, the apical surface. This is your alveoli. We're just looking at your beautiful alveolar sacs. Question: destruction of the alveolar sacs. What's the pathology? Destruction of the alveolar sacs.
Emphysema.
Emphysema, excellent. What happens in emphysema?
You have a overactivity of elastase.
Excellent. Good job. So overactivity of elastase. What is the function of elastase?
It breaks down the elastic fibers, so then like they end up having like they're just called like a permanent dilation of the airways.
Excellent. It's like a plastic bag from CVS, right? If you blow on the paper on the plastic bag, it just poof, it blows out. So that's your alveolar sac in emphysema. Another cause, genetic cause of emphysema.
Alpha-1 antitrypsin deficiency.
Alpha-1 antitrypsin. What's the normal function of alpha-1 antitrypsin? The normal function of alpha-1 antitrypsin.
It counteracts the elastase.
Excellent. It antagonist to your elastase. So if you have an alpha-1 antitrypsin deficiency, what happens to the activity of the elastase? Increase or decrease? Increases. So we have a destruction of your alveolar sac. Thank you very much. Good job, guys. So, conducting zone. Again, trachea and bronchi. Do I need to know the epithelium for histology? Yes. Pseudostratified, ciliated, columnar epithelium. Why is this important? Mucociliary clearance. What else is in there? Goblet cells. What else? Cartilage. You have a C-shaped hyaline cartilage bounded together by what? Annular ligaments. You have smooth muscle there, and you have the seromucous glands. Bronchioles, what happens to the epithelium? It becomes simple, ciliated, columnar epithelium. How about in terminal bronchioles? There's still cilia. Simple, ciliated, cuboidal epithelium. As we go down from the conducting zone to the respiratory zone, we are changing the epithelium. We're making the epithelium thinner and thinner. We are also removing the cilia as we go down. Respiratory bronchioles, what's there? What kind of epithelium? Simple, cuboidal, and squamous. Now, club cells is also in there. What's the function of a club cell? They degrade toxin, and they maintain the integrity of your respiratory epithelium. Now, we go to the high-yield stuff, the pulmonary alveoli. Two kinds of pneumocytes, type 1 and type 2. Which one secretes surfactant? Type 1 or type 2?
2.
Type 2. Where is this enclosed? The surfactant is enclosed where? It is contained where, specifically in your type 2 pneumocytes?
The laminar bodies.
Lamellar, excellent. So lamellar bodies. Another function of your type 2 pneumocytes, aside from producing surfactant, another high yield.
There are stem cells.
Excellent, good job. I'm so proud of you guys. So this is stem cell. So what if I have surfactant? What is the function of this surfactant that we're talking about?
Reduce surface tension.
Excellent. So it reduces your alveolar surface tension. So what? It prevents your alveoli from collapsing. So what? Decrease work of breathing so that you can breathe easily. Sometimes they trick you. They will not gonna put surfactant. They're gonna put DPCC or they're gonna put lecithin. It's the same thing. It is a phospholipid, right? So surfactant, another term, DPCC, don't be fooled, or lecithin, right? How about type 1? So what's the function of type 1 then?
It forms the blood-air barrier.
Good job. So it is connected by tight junctions. Can you tell me other junctional complexes that you know aside from tight junctions?
Are you talking about like the zona occludens, claudins?
Yeah. The claudins. I want you to remember two: desmosomes and hemidesmosomes. Why? There's a pathology that's involved there. In desmosomes, what is this? What pathology? Skin pathology. Did you talk about bullous pemphigoid and pemphigus vulgaris?
Yes.
Of course, yes, I remember. Right? So what's the difference? Desmosomes is what?
Vulgaris.
Pemphigus vulgaris. What can we see in immunofluorescence?
It's going to look like a fishnet.
It's a fishnet. Excellent. It's a fishnet. Why? What's the deficiency there? Your desmosomes. Okay. That's a deficiency in your pemphigus vulgaris. Term 4, you're going to learn the difference between pemphigus vulgaris type 1 and pemphigus vulgaris type 2. But that's one step at a time. Okay. How about bullous pemphigoid? What's the problem there?
Hemidesmosomes.
Hemidesmosomes. What can we see in immunofluorescence?
It's like a swirl that kind of goes up. I don't know. It's kind of like a straight line.
In the epidermal dermal junction, you can see a thickening. You can see the immunofluorescence like green in between the epidermis and the dermal junction. Why? Because there's a separation there. Right? Hemidesmosomes is the one that connects your epidermis from your dermis. So if you have a deficiency in your hemidesmosome, if they're gone, then you can see a separation. Which one is positive Nikolsky sign? And what is Nikolsky sign?
Vulgaris, and it's just I think like a test of like how bad pemphigus vulgaris is.
Excellent, good job. Pemphigus vulgaris. Nikolsky sign is when you put pressure on the blister, it pops. Why is this important? Because they are much more prone to infection. So guys, if you have a blister, don't pop it, okay? Just let it stay there. I know it's uncomfortable. So put some padding, because when you pop it, you are much more prone to infection, and you don't want that. Good job. Let's summarize, okay? Pulmonary alveoli, separated by a septum. What's in there? Type 1 pneumocytes. Connected to each other by tight junctions. What's the function? It forms the blood-air barrier. Type 2 pneumocytes. It's the function. Secretes surfactant. Where can you find surfactant in type 2 pneumocytes? Your lamellar bodies. Surfactant is made up of what? Composed of DPCC, dipalmitoyl phosphatidylcholine, or lecithin, and phosphatidylglycerol. What's the function of surfactant? It reduces alveolar surface tension and prevents alveoli from collapsing, thereby decreasing your work of breathing. Another function, high yield of type 2 pneumocytes, they proliferate, your stem cells, to replace type 1 or type 2 pneumocytes following lung damage.
Can I ask a question here, Nick?
Go ahead.
So I know pneumocytes or the surfactant prevents collapse. So why is it an issue when there's excess fluid on our alveoli and things like that? I know it affects diffusion, but which one would be more detrimental? I assume collapse, obviously, but would excess fluid not allow the prevention of that collapse as well?
I think it will not prevent. So your question, if your question is, does the fluid in the lungs prevent collapse of your alveoli?
If there's like an excess accumulation of fluid, like when there's extra fluid in our lungs, that would assist in preventing collapse as well, or? I know that affects the diffusion barrier and makes it not as efficient, I guess.
Thickening. You have, yes. So the diffusion doesn't go through, but I think it pushes your alveolar walls closer, so it cannot expand well. Can I just say that? So you're gonna have congestion also of your alveolar sac, so it doesn't expand that maximal size. So law of Laplace, right? Law of Laplace. If you increase physics, if you increase tension, right? So it doesn't inflate into its maximal size because you have congestion there, you have fluid, so it doesn't expand.
Well, sweet, thank you so much.
No worries. So alveolar macrophage, what is the function of that? Macrophages? Okay, guys, there are different kinds of macrophages, right? Kupffer cells, they said, where can we find Kupffer cells?
The liver.
Excellent. So please know the different names, okay? I'm not sure if it's high yield or not, but please know the different names. Here, alveolar macrophages. They produce what? Elastase, right? Elastase is degraded by your metalloproteinases. So increased elastase activity is associated with the development of emphysema. Don't forget, hemosiderin-laden macrophages can also be present in alveolar alveolar hemorrhage. So if I have hemorrhaging in my alveoli, I can see hemosiderin-laden macrophages. But the pathology that I want you to think when you hear hemosiderin-laden macrophages is congestive heart failure. You can always see that in someone who has congestive heart failure. Right. Again, yada, 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 type 1 pneumocytes, type 2 alveolar macrophages. You can read that. Okay, NRDS, neonatal respiratory distress syndrome. Risk factors. Tell me risk factors for this.
Premature birth.
Premature birth. Okay, again.
Diabetes.
Maternal diabetes. Why? You have increase in insulin. Another one. C-section delivery. Why? C-section delivery. Think about this. So actually, the stress of vaginal birth, it helps with the development of your lungs. It helps with lung development. The theory is, on vaginal birth, you increase cortisol. And cortisol is very important in development of your surfactant. Okay, so if the child is premature, it's a preemie, and then it's a C-section, you don't have that cortisol in the baby, so you have an underdeveloped lungs. So what are we going to treat? High yield if you have a neonatal respiratory distress syndrome, which is caused by a decrease in surfactant, right? You can see on the x-ray here, a ground glass appearance. They love that in the vignette, ground glass appearance of lung pills. What's the treatment? You give maternal steroids before.
Corticosteroids?
Yes, excellent. You give maternal steroids before birth. Before birth. What if the child is there already? It's already delivered and the child develops NRDS. You can give exogenous surfactant to the infant. Careful in treating NRDS. The treatment is supplemental oxygen. It works, yes, but be careful if it's high flow. This is a kid. It's a preemie, usually premature, right? And you're giving 100% high flow oxygen. Careful. Why? It can result in blindness, retinopathy of prematurity. Another one, intraventricular hemorrhage. It can induce direct hemorrhages in the brain. When you go to term 2, you're going to learn about the middle cerebral artery. The middle cerebral artery has different branches. One of them is your lenticulostriate artery. It's one of the most sensitive arteries in the body. If you increase your oxygen level, it's a preemie, increased pressure in your blood vessels, it can induce hemorrhage in the brain. Another one is your bronchopulmonary dysplasia. Remember, you don't have any surfactant, right? It is decreased, it is deficient. Your lungs cannot expand fully well, and you're giving 100% high flow oxygen. So what's the screening for this? It is preventable, yes. So you do LS ratio in amniotic fluid, more than 2. So guys, they're going to give you a graph. Look at the graph. Pay attention to the graph. Where is lecithin and where is sphingomyelin? The lecithin is always higher than your sphingomyelin. Okay, don't get tricked. 2-to-1 ratio, meaning lecithin is twice as much as your sphingomyelin. That's high yield. If you have a persistently low oxygen tension, what happens? Risk of PDA. Let's go back to CPR1. What is PDA?
Patent ductus arteriosus.
Patent ductus arteriosus. Ductus arteriosus is a communication between what and what?
Between the aorta and the left ventricle?
Between the aorta and, there's another one.
Is it the left ventricle?
It's not
The
the
pulmonary artery.
Pulmonary artery. Excellent. What is the adult derivative of your ductus arteriosus? The adult derivative of your ductus arteriosus.
Ligamentum. I don't know this word, but I know it's ligamentum.
Excellent. Ligamentum arteriosum. It's an abnormal connection between your aorta and your pulmonary artery. What nerve hooks underneath your ligamentum arteriosum? Where's my anatomy guy? What nerve hooks underneath your ligamentum arteriosum?
So vagus.
Your left.
Laryngeal.
Go ahead. Tell me.
Left laryngeal.
Again. I'm sorry.
Left laryngeal.
So left recurrent laryngeal nerve. Term 2, you're going to learn that the vagus nerve has 2 parts, left and right recurrent laryngeal. Your right recurrent laryngeal nerve, it hooks underneath your subclavian. Okay? On the left side, it hooks underneath your ligamentum arteriosum. Question then, if it hooks underneath that, if I have an enlargement of the heart, give me a symptom that can develop in a patient.
Hoarseness.
What am I doing? Coughing. So you can have hoarseness, you can have coughing because you have irritation of your left recurrent laryngeal nerve. Anything that, if you have cardiomyopathy, right, you can have hoarseness. Vagus nerve, it's about hoarseness, so you can have also coughing. Question again, PDA. Let me think back to term 1. How to open? Keep them open. Why? Normally, if you have a comorbidity, like a foramen ovale, an open foramen ovale, you need that blood flow. So you keep, the only thing for the baby to survive is to keep that PDA open. So what am I going to give to keep it open before the surgery is done? What am I going to give? Anyone?
PGE 1.
Excellent. PGE 1 and PGE 2. Don't forget to keep them open. How about to close it? The surgery is done. The foramen ovale has been repaired. What am I going to give to close your patent ductus arteriosus?
NSAIDs.
NSAIDs, specifically an indomethacin.
Yeah.
Indomethacin, right? Or NSAIDs. Prostaglandin. How am I going to synthesize prostaglandin? tell me about the synthesis of prostaglandin. From where to where? From where to where? What's the derivative of your prostaglandin? You have Google there, search.
Arachidonic acid.
Arachidonic acid. So from your sterol membrane, your cholesterol membrane, remember the sterol membrane, you can just get your stuff from there to make arachidonic acid. Give me a drug that inhibits the synthesis of arachidonic acid.
Cortisol.
Excellent. So you have your corticosteroids, any kind of steroid drugs. Remember, they are lipophilic, right? How do they interact with the cell? How do they affect the expression of receptor in the cell? They just go into the phospholipid membrane and they just go into the nuclear membrane because they're lipophilic, right? That's how they induce the receptor to regulate the receptor. So from arachidonic acid, and then where? COX-1 and COX-2 to get your prostaglandins. If I want leukotrienes, so lipoxygenase. Don't forget, guys, this is high yield, okay? Lipoxygenase, then you have leukotrienes. We have an intermediate step there, 5-HP, and then from 5-HP to your leukotriene. So let's summarize. Yes. Are you okay? So you have your phospholipid bimembrane, arachidonic acid. Steroids block the synthesis of arachidonic acid. From arachidonic acid, COX-1, COX-2 to become prostaglandin, different kinds of prostaglandins, and from boxing also. Then, if arachidonic acid to 5-HP via lipoxygenase, from 5-HP, you're going to have your leukotrienes. More of the function of your prostaglandins and leukotrienes in next term. Okay? It's just a PDA. Good. Again, conducting zone. Put a start here. Check for the differences. As we go down from the conducting zone to the respiratory zone, we are slimming down the epithelium. We started with pseudostratified ciliated columnar epithelium. Look, it becomes simple ciliated cuboidal, and then simple squamous epithelium. As we go down, look at the cilia. It's going out, right? So from the trachea, we still have cilia. When we go to the bronchioles, we still have cilia. When we go to terminal bronchioles, we still have cilia, but no more cilia in the respiratory zone. Again, as we go down, the club cells is there, except for the alveolar sacs. So for this image, put a star here. Check what's the difference. What's going on in each zone? What is diminishing as we go down from the conducting zone to the respiratory zone? What kind of cells are being removed from the conducting zone to the respiratory zone? This is just an image. Again, left is less lobe, the lingula, we'll talk about that one, the RALs. Okay, high yield, put a star here, the diaphragm structures. I ate 10 eggs at 12. Good. I ate T8, vena cava. T10, esophagus. T12, aortic hiatus. C3, C4, C5 keeps the diaphragm alive. What nerve is this? C3,
Phrenic.
C4, phrenic nerve. Excellent. Common bifurcation. Common carotid, C4. Trachea, T4. This is your carina. And then abdominal aorta bifurcates at your L. Again, aspiration of foreign bodies, more likely to enter the right primary bronchus and pass into the, not the middle, lower lobe bronchi. Pneumonia. Pneumonia is an inflammation of the lung, commonly caused by bacteria, viruses. We're going to learn more about this in term 3. Symptoms, coughing, chest pain. In the chest x-ray, you have opacity of the lung parenchyma and enlargement of what node? Bronchomediastinal lymph nodes, high yield in pneumonia. You have the bronchomediastinal lymph nodes. Why? Because your mediastinum is widening, because we have inflammation. Bronchogenic carcinoma, more of this in term 4, arises in the mucosa of the bronchi. Signs and symptoms: cough, hemoptysis, coughing up blood. Where is the early site of metastasis? High-yield bronchomediastinal lymph node. Hematogenous spread to the brain, bones, and lungs. Hematogenous meaning it spreads via the blood. So a tumor at the apex of the lung, you have a Pancoast tumor, may result in thoracic outlet syndrome. Signs and symptoms of someone who has thoracic outlet syndrome. Tell me.
Paralysis in the upper limb or arms.
Okay, good job. What else?
It's a C8 to T1, like nerves are affected.
So if I have a C8 to T1, signs and symptoms. Pancoast.
I think cyanosis in the upper limbs.
You can have that, yes.
One giveaway is a floating rib.
Okay. Up. Oh, someone's calling. Auscultation. Do I need to know this? Middle yield. To listen to breath sounds of the superior lobes. It's above the 4th rib for the right lung and above the 6th for the left lung. I think this is low yield. This is much more important for your OSCE. Do you still have OSCE?
Yep, on Thursday.
Okay, good luck, guys. So open pneumothorax, high yield again. If someone stabbed me, right, the lungs, have a collapse of the lung. Open pneumothorax, meaning the pleural cavity is open to the outside air. So air moves freely through the wound. So during inspiration, the air enters the chest wall, and the mediastinum will shift towards what? The other side, high yield, and it will compress the opposite lung. Open pneumothorax. Okay? Nerve supply of the pleura, middle yield. Costal pleura, intercostal nerves. Mediastinal pleura is the phrenic nerve. Don't forget that the visceral pleura is sensitive to stretch, but insensitive to general sensibilities. That's why if you have like a lung cancer, it's very hard to detect. Why? Because remember, the lungs is surrounded by your visceral pleura. It is an autonomic nerve that is supplied from the pulmonary plexus. It is sensitive only to stretch. Okay, so you don't feel any pain, and you have lung cancer now. Don't forget that, okay? Visceral pleura, sensitive to stretch only, but insensitive to general sensibilities. That's why it's hard to detect lung cancer. Parietal pleura, it is sensitive to general sensibilities. Why? It's somatic innervation. Costal pleura via intercostal nerves, mediastinal pleura via your phrenic nerves, C3, C4, C5, and you also have a diaphragmatic pleura. This is the phrenic nerve over the domes of your diaphragm. All right, let's skip this one, rapid fire concepts, and let's do physiology. Okay, you ready? This is a much more high yield, I think, much more challenging part of today's session. Okay, guys, let's do this. Lung volumes versus lung capacities. Tidal volume, normal inspiration, normal expiration, approximately 500 ml. Normal inspiration, and then you inspire more air. Inspiratory reserve volume. At the point of normal inspiration, you add more air. That's your IRV. Inspiratory reserve volume. We expire normally. At the end of normal expiration, we expire more air. That's your expiratory reserve volume. Okay? There's another volume. It's in your alveoli. This is your residual volume. It doesn't go whether you expire extensively, right? It's there. Why? To prevent alveolar collapse. Know the definition of each lung volume. If we combine the lung volume, we can have lung capacities. Know them, know the formula, how to calculate them. Inspiratory capacity, IRV plus TV, tidal volume plus inspiratory, reserve volume. Vital capacity is everything except residual volume. Total lung capacity is everything, IRV plus TV plus ERV plus RV. You might ask me, so what, Nick, if I know these lung capacities and lung volumes? What's this significance? This is significant in diagnosing whether a disease is obstructive or restrictive lung disease. Now, question. Chronic obstructive pulmonary diseases, your chronic bronchitis, your emphysema, and your bronchiectasis. Tell me what happens to the volume. What happens to the volume?
You have trapped air, so you can't let things out. I would assume the volume would decrease.
Careful.
No, you will have an increase in the TLC.
Okay, let's do it one step at a time. Look at the lung volume here. If I have an obstructive COPD, what happens? Air trapping. Someone said it. That's right. Air is trapped in the alveoli. If air is trapped in the alveoli, what happens to my residual volume?
Does that go up?
It does. It does go up. It goes up. So RV increases. If my RV is increased, what happens to my functional residual capacity now?
It would also go up.
It also go up. If my FRC goes up, what happens to my total lung capacity?
Will go up.
Excellent. Good job. So that's how I would like you to think. Okay? So you just read there in your notes, oh, increase in TLC and FRC, like why? So you need to explain it physiologically. What's happening? The alveolar sacs, right? They are dilated, maximally dilated. So you're having more air there. Air cannot get out, right? So you have increase in RV. So we have also increase in functional residual capacity. What is FRC? What is functional residual capacity in layman's term? This is the volume that is inside your lungs after a normal expiration. That's it, basically. ERV plus your RV. Another one, physiologically, the outward expansion of your chest and elastic recall of the lung is equal at your functional residual capacity. Another one is at FRC, the pressure outside, atmospheric pressure, and your alveolar pressure is equal to 0 at FRC. I want you to remember those at functional residual capacity. Okay? Good. Obstructive COPD, increase in RV, increase in FRC, and increase in TLC. How about FEV1 FVC ratio? What happens? FEV1 to FEV ratio. Decrease FEV1. Right? That one is decrease. Good job, guys. Put a star here. Know the lung volumes. Know the definition. Again, this is from first aid. Okay, oxygenation of blood. What's the function of the lungs? For gas exchange, of course, we need to exchange oxygen and CO2 so that we can be alive. Via what? There's a blood-air barrier there. What's a pneumocyte that develops that? Type 1 pneumocytes. What kind of transport? Simple diffusion. Does it require energy? Of course not. It's simple diffusion. It follows pressure gradients, meaning it flows from high energy to low energy, or from high pressure to lower pressure. The capillaries, don't forget the oxygen. They bind to your hemoglobin in erythrocytes or dissolve into plasma. High yield diffusion of gases depends on what? First, their composition. Second, difference in your partial pressure. Don't forget, from physics, the gas moves from an area of When the partial pressure is higher to partial pressure that's lower. It also depends on solubility of gases. CO2 is much more soluble than O2, and O2 is much more soluble than N2. Also, the surface area of your alveolar capillary membrane. So if you're smoking, that's gone. It's thickened, right? And also thickness of alveolar capillary membrane. High yield, don't forget, the diffusion of gases depends on these these 5 factors, okay? Don't forget those. High yield, the diffusion capacity of the lung is decreased in what? Emphysema. Why? Decreased alveolar capillary membrane surface area. Another one, interstitial lung disease and pulmonary fibrosis. Why? Thickening of your alveolar capillary membrane. Anemia. Why? You have fewer RBCs, remember. You need your RBCs to transport the oxygen. You have hemoglobin there to transport the gases. Pulmonary edema. Why? Because it hinders your gas flow. More of this interstitial lung disease and COPD in term 4 for your pathology. AA gradient. So what's the point of this AA gradient? Why do we need to know the formula for AA gradient? Because it assesses the functionality of your blood-air barrier, which is composed of type 1 pneumocytes. So what? So that you can know what causes the hypoxemia. Is a low oxygen due to intrapulmonary or extrapulmonary? Is it due to pulmonary embolism, or it is due to congestive heart failure? So this is important clinically. You have calculators in the hospital for this. Online also. So what's the formula? What is this? It's a difference in the partial pressure of the oxygen in the alveoli and the arterial partial pressure of oxygen. What's the formula? P big AO2 minus P small a O2. High yield, the AA gradient increases with what? As we grow older, like I am, like all of us, the AA gradient increases. When there's a right to left shunting, AA gradient increases. When there's a fluid in the alveoli, congestive heart failure. Question, difference between left-sided heart failure versus right-sided heart failure in terms of symptomatology. Where can we find anasarca or generalized edema? Left-sided or right-sided? Hello? Google, if you don't know the answer. Where can we find anasarca or generalized edema? Left-sided or right-sided?
Isn't it right-sided?
Right-sided heart failure. Excellent. Where can we find pulmonary edema?
Left side.
Left-sided. Where can we find jugular venous distension? Typically.
Right-sided.
Right-sided. Right. Because you're also compressing the lymphatic duct there. Right? Good job. VQ mismatch due to increased dead space. We're going to talk about VQ mismatch later. High yield. Pulmonary embolism. Think pneumothorax. Think atelectasis. Think COPD. Think pneumonia. Think pulmonary edema. Everything that increases the dead space. Right? AA gradient also increases. How about hypoventilation? Lung fibrosis, or if your patient is obese, you have hypoventilation syndrome. In obesity, AA gradient also increases. So don't forget, know the formula, know the use of AA gradient, and another high yield. If it increases with what? Okay, so this one here, with a star there. Do I need to know the formula here? Yes, still gonna throw you. This one probably an experimental, hopefully an experimental question, right? Pico, Paco, Echo. All right, but don't forget, they're gonna give everything except for one variable. So it's like a single variable algebra. Okay, it's basic math. What's ventilation? Ventilation means the distribution of respiratory air. the different parts of the lungs. Respiratory rate, the number of breaths per minute. Normal respiratory rate. What's a normal RR?
8 to 12.
8 to 12.
I think 12
How
the
about
normal. It's like 8 to 14.
8 to 14, yes. Yep. How about tidal volume? The volume of air that is inspired or expired in a single breath. So normal inspiration and expiration, typically 500 ml. Minute ventilation and alveolar ventilation. Know the formula. Minute ventilation, the volume of air that a person breathes per minute. Alveolar ventilation is the volume of gas that reaches the alveoli each minute. For alveolar ventilation, what's the formula? Tidal volume minus physiologic dead space multiplied by respiratory rate. We're talking about physiologic dead space. What does it mean, physiologic dead space? So it means the volume of inspired air that does not participate in gas exchange. What are the components? Anatomic dead space, air conducting zone, mouth, trachea, all of those. And you also have alveolar dead space. The physiologic dead space is the sum of your anatomical dead space. This is your conducting zone, and your alveolar dead space. You also have alveolar dead space in your apex of the lung. So what's the formula? How are we going to determine the physiologic dead space? High yield again. Tidal volume, it's here, multiplied by arterial PCO, the difference of your arterial PCO2 and the expired air PCO2 divided by arterial PCO2. In a healthy lung, the VD, the physiologic dead space, equals the anatomic dead space. So in a healthy lung, that's a caveat, right?
Can I ask if you're posting these slides, Nick?
It's on the chat. So,
okay, sweet.
Yeah, yes. It's in there. I'm gonna post the chat for the renal system later. So we're gonna have a break later. Okay. So VD is greater than anatomic dead space. Where? When does it do that? During VQ mismatch. Think about pulmonary embolism. So this slide is very high yield. Know the formula for minute ventilation, for alveolar ventilation, for the Bohr equation for the physiologic dead space. The components of your physiologic dead space. In a healthy lung, VD is always equal to the anatomic dead space. VD only increases to the anatomic dead space when you have diseases with a VQ mismatch. For example, pulmonary embolism. Don't put a star here, please. Minute ventilation, know the formula. Alveolar ventilation, know the formula. Medium yield, determination of physiologic dead space. This is the PACO. As usual, one variable is missing, so you just do algebra, single variable algebra to find the correct answer. They give you everything except for one variable. Perfusion. Perfusion is important. Why? Because remember, the entire blood volume of the body, they must pass through the lungs. So the pulmonary circulation, it corresponds to the cardiac output. You have this one. However, don't forget, how do we regulate the ventilation and perfusion? So if a lung section is perfused but not ventilated, so you have blood there in that section of the lung, but there is no oxygen. There is a drop in the oxygen concentration in the blood. What happens? You have hypoxic vasoconstriction, high yield, only in the lungs. When there's a drop in oxygen concentration in the blood, you can have vasoconstriction. Other organs in the body, when you have low oxygen concentration in the blood, they vasodilate. Okay, so that's high yield, only in the lungs. And there is a drop in oxygen concentration, you have hypoxic vasoconstriction. Don't forget also, the VQ ratio is higher in the lung tip than in the lung base. Why? The oxygen partial pressure are higher in the lung peak than in your lung bases. Now, put a star here. This is high yield, VQ mismatch. This is the most common cause of hypoxemia, low oxygen concentration in the blood, characterized by what? Increase in AA gradient. If I have a VQ mismatch, I guarantee you there is an increase also in the AA gradient. I guarantee you there's also hypoxemias. You can see signs and symptoms of hypoxemia. Why do we have VQ mismatch? There's an imbalance between ventilation and perfusion, between airflow, V, and blood flow, Q. What's the normal ratio? 0.8, right? So remember, the lung bases, we have your lungs, the lung bases, the lower lobes, they are better ventilated and perfused than the apices of an upright person. So if someone has tuberculosis, they love air, so where do you think they were going to develop? Upper lobe or lower lobe? Tuberculosis, Mycobacterium, tuberculosis, they love air. Where do you think they're going to go? Lower lobe or upper lobe of your lungs?
Would it be lower because there's a higher perfusion?
Excellent, yes, because they're better ventilated and perfused than the apices. Excellent, good jobs. Two types of mismatch, dead space and shunt. If V is greater than Q, it's dead space. If V is less than Q, it's shunt. High yield, put a star, pathologic changes. Decrease in VQ ratio, meaning you're increasing the shunt. Due to what? Decreased ventilation. Think pneumonia, atelectasis, cystic fibrosis, pulmonary edema. You're increasing the shunting, you are decreasing the ventilation. Another one, if VQ ratio is increased, think you are increasing the dead space, meaning we are decreasing the perfusion. Think about pulmonary embolism. Think about cardiovascular shock. If VQ is equal to 0, it means there's an airway obstruction. Think foreign body aspiration. If VQ is infinite, it's due to blood flow obstruction. Think pulmonary embolism. Don't forget VQ mismatch. Normal VQ ratio 0.8. Lung bases are better ventilated and perfused. Tuberculosis wants to go there. Pathologic changes, don't forget, decreased VQ ratio. What are the diseases that do that? And increased VQ ratio, what are the diseases? If VQ is equal to 0, you can see this in airway obstruction. If it's VQ is infinity, we can see this in blood flow obstruction. Okay, those are high yield. How are we going to regulate respiration? Is it due to increased oxygen drive or increased CO2? That's my question. What is a respiratory drive? And could you tell me what part of the brain can we find the respiratory center? I think this is a DLA in your term. Much more, we're going to learn more in term 2, but I think it's a DLA. The respiratory drive, where can you find it? It's in the pons, but where in the pons?
Is this like the pre-Botzinger?
Good job, excellent, excellent. You have your Botzinger, pre-Botzinger, and your Botzinger in the pons, right? So remember, under normal conditions, the strongest respiratory drive is increase in partial pressure of CO2. Okay, normal people, normal conditions, increase in PCO2. However, if someone has COPD, right, the drive is low PO2. Okay, low PO2. So I have a question, guys. Someone came in. They said, doctor, this patient has COPD. Should we give 100% high flow, 4 liters of oxygen? The patient is hypoxemic. He has cyanosis. Should we give 100%?
No.
Liters of oxygen? And please tell me why you should not put them in a high flow oxygen. Go ahead.
Because there's still an obstruction in the airway, so there's no way that if we give the patient 100% oxygen, it's gonna get through.
We just talked about your respiratory drive. I want you to think in terms of what we just talked about, the respiratory drive. We just talked about this. So why? You're right. You can't give 100% PO2, but why? Someone who's hypoxemic, who has COPD. Because what's the drive in someone who has chronic hypercapnia, like in COPD? Low partial pressure of oxygen. You're giving them 100% via nasal cannula, right, at 4 liters of oxygen. The body will think that they have good oxygen. So what happens to the respiratory drive? It decreases their respiratory drive. So you don't give 100% oxygen in someone who's suffering from COPD because they are chronic hypercapnic patients, right? The respiratory drive is due to low PO2. If you give them high oxygen, the pre-Botzinger complex says, oops, the patient is adequately oxygenated. Let me lower down my respiratory drive even further. So what do you give? If it's not 100%, what do you give? 90 to 92%. That's it.
So
why? So that the respiratory drive will not be depressed. You don't want the respiratory drive in a chronic hypercapnic patient to be more depressed. Okay? That's the reason. That's a simple reason why you don't give 100% oxygen. Are we clear on that one? Yes?
So you're saying by giving more oxygen, by giving 100% oxygen,
you are depressing the respiratory drive of that patient.
Okay.
Gotcha. Because why? What's the drive in a chronic hypercapnic patient, like in patients who has COPD? What's the drive? Low PO2. That's why they keep on breathing because there's low PO2. If you give them 100%, the body will think, oxygenation is good. Let's depress the respiratory drive even further.
Right. Okay.
Yes. Good job. Okay. High yield, don't forget that one. But in normal conditions, it's usually CO2. Do I need to know this? Simulation of central? Yeah, probably. Low yield still. So guys, if you have questions on the chat, please check the chat. I can't do two things at a time, sorry. If you have questions there, I'm gonna answer your questions after this because we're gonna have a couple of minutes break, okay? Again, let's do mechanics of breathing. When I breathe in, inspiration, what happens to the diaphragm? Contract or relax? Inspiration, what is the diaphragm? Contract or relax?
It contracts.
It contracts, so it goes down. What happens to my intercostal muscles? Contract or relax? Inspiration. You're also contract. What happens to my lungs? Expand or collapse? Inspiration. They expand. What happens to my rib cage? Expand or collapse? They expand. Okay, guys, when you're learning physiology, learn it step by step. It makes it easier to think. Normal inspiration, what's happening? Diaphragm is contracting. Why is it contracting? I am creating a much more negative pressure in my abdomen so that what? My lungs can expand. My ribs can expand. My intercostal muscles are contracting during inspiration. During expiration, everything goes back to normal. Relax. Okay? Basic mechanics of breathing. Know that because next slide we're going to learn about the pressures. High yield. I love this slide. Inspiration and expiration. During normal inspiration, what happens to the intrapulmonary pressure or the pressure in your alveoli? they decrease. So from 0, look at this. So this is dynamic compliance. We're not doing static compliance, because if it's static compliance, it means you're dead. You're not breathing anymore. So hopefully we all are in dynamic compliance, right? So we're thinking about the orange line here. So 2 phases, inspiration and expiration. Pay attention to intrapulmonary pressure and intrapleural pressure. Pay attention to the dynamic compliance. We don't care about the static compliance. During normal inspiration, intrapulmonary pressure becomes more negative, from 0 to -1. What happens to intrapleural pressure? From -5, it goes through negative, looks like 7 there. Okay, during expiration, what happens? The intrapulmonary pressure becomes positive. Expiration, the intrapleural pressure becomes less negative. Based on this graph alone, what pressure is always negative? High yield. Based on this graph alone, which pressure is always negative?
The intrapulmonary pressure?
Careful, look at the graph, carefully.
It's the interpleural.
Intrapleural pressure is always negative. Remember, during inspiration, -5. It becomes more negative during inspiration. During expiration, it becomes less negative. Look at the graph, -0.5. The intrapulmonary pressure, it becomes negative during inspiration. It becomes positive. So that's high yield. So why? Inspiration, it requires a negative intrapulmonary pressure. How are we going to achieve that? Expansion of the lungs. How? Via contraction of your diaphragm and intercostal muscles. During exhalation, the intrapulmonary pressure becomes positive. Why? Because of the elastic recoil of the thoracic wall, which compresses the lungs and expels the inhaled air. Put a star here. Understand what happens to these 2 pressures during inspiration and expiration. They are very high yield. Again, this is one intrapleural pressure. It remains negative in relation to atmospheric pressure, ensuring the lungs do not collapse. During inspiration, the diaphragm and the intercostal muscles, they contract. This causes the thorax to expand and the intrapleural pressure to become more negative, drawing air into the lungs. During expiration, the diaphragm and intercostal muscles relax. This causes the intrapleural pressure to become less negative and air is forced out of the lungs. Let's summarize this. Inspiration, 1 atmosphere, right? Atmospheric pressure, 1 atmosphere is equal to 760 mmHg, millimeters of mercury, right? This is physics. Higher pressure. We need to create in our lungs a negative pressure so that the air can go from higher pressure to lower pressure. That's the principle of physics. How are we going to create a negative pressure in the lungs? Simple. Breathe in, inspiration. Your diaphragm contracts, intercostal muscles contracts, rib cage goes out, expand, lungs expand, intrapleural pressure becomes more negative, from -5 to -7. Intrapulmonary pressure becomes negative, from 0 to -1. That's during inspiration. During expiration, what happens? Diaphragm relaxes, intercostal muscles relaxes, rib cage goes back to normal size, lungs collapses, we expire the air. Intrapulmonary pressure becomes positive, from 0 to positive 0.1. Intrapleural pressure becomes less negative, from -7 to -0.5. That's how I want you to think about lung physiology. Okay? Watch this video later. Have that understanding if you still don't get it. Okay? Good. Chest wall dynamics. You have the resting, expiratory position. Remember, FRC, right? The atmospheric pressure is equal to your alveolar pressure. At FRC also, the pulmonary vascular resistance is at its lowest. And we talk about what happens to the pressures during inspiration and expiration. Put a star here. This is your hysterexis, your lung thorax hysterexis, right? So pay attention to the purple line. I want you to pay attention to the purple line. So the blue line is about the lungs. What's the natural tendency of the lungs? Is it to expand or to collapse? What's the natural tendency of your lungs? Is it to expand or to collapse? Guys. What are we thinking?
Collapse.
To collapse. Excellent. So the lung collapses. That's a natural tendency. How about the thorax? What's the natural tendency of the thorax?
To move outward.
Excellent. To expand. Okay. But remember, at FRC, there needs to be a balance between the pressure of the lungs to collapse and the pressure of your thorax to expand. We call this one here, the purple line here. At FRC, these two forces are at a balance. So, high yield. If you have COPD, what happens to this pressure here? Look at this one here. This dot, right? Does it go up or it goes down? COPD, does it go up or does it goes down? Where does it go?
Goes down. Down.
Are you sure about that?
Wouldn't it go up?
Go up.
It will go up. Why? Because you're increasing the FRC, right? You're increasing the RV, you're increasing the FRC, you're also increasing the TLC, okay? Increase in RV, increase in FRC, increase in TLC. Good job. Yada, yada, yada. We talked about that one. Here is another graph for that. Okay, what happens? High yield. When we age, don't forget, everything decreases. Remember, your lung capacities, they decrease, except for one, high yield, TLC. It remains the same. Don't forget, that's high yield. Everything, all of the lung capacities decreases except for TLC. Lung compliance increases, RP increases, VQ mismatch increases, AA gradient increases. Lung compliance, the ability of the lungs to withstand under pressure. You can have change in the volume of the lung per unit change in pressure. So C, lung compliance is equal to delta V divided by delta P. Lung compliance increases in what? Emphysema. Don't forget destruction of the alveolar walls. The lungs feel easier in aging. It is decreases in restrictive lung diseases. Example, pulmonary fibrosis, pulmonary edema. Now, question, guys. Look at the graph. It looks like an anomaly. Right? It looks like a QAnon conspiracy at the graph. As you go down from the conducting zone to the respiratory zone, why is the resistance also going down? Isn't the normal physical in physics, right? If you're going from a larger diameter to smaller diameter, the resistance should go up. That's physics. How come in this one, the resistance goes down? Can someone tell me why?
Is it because with the alveoli, we look at them in bundles, like sheets of them together, which means like a bigger area, I believe?
So excellent, good point. So remember, one trachea, what happens? It divides into two. And then your left and right main bronchus divides into different branches. So you have parallel branching. That's why you have a decrease in resistance. Think about circuits in physics, right? The resistance in parallel is 1 over R, right? If it's in series, you add the resistance R1 plus R2 plus R3 to infinity, right? Here, we have branching. Branching out, that's why your resistance decreases. It's not a conspiracy. It is decreasing because of parallel branching. Excellent. So it depends on diameter of the airways. You're right. The smaller the diameter, the greater the resistance. The velocity of airflow. What's a normal velocity? Laminar. Viscosity of gases. And the number of parallel pathways. High yield, the resistance reduces at each generation of branching. Where can we find greatest resistance? Segmental bronchi. Exercise is good because it decreases airway resistance. Lung physiology, what happens? This is a DLA. During exercise, you have increased depth and rate of ventilation, increase in pulmonary blood flow, you have a vasodilation in your apical pulmonary capillaries, decreasing the VQ ratio. Also, oxygen diffusion, increase in oxygen diffusion. Put a star here, this is high yield. Now, let's talk about hemoglobin. What's the function of hemoglobin? To take up oxygen from the lungs and deliver it to the tissues. It undergoes conformational change depending on the state of oxygenation. Deficient or defective hemoglobin can affect the transport of oxygen. Yada, yada, yada. Hemoglobin is composed of 4 subunits, 2 alpha, 2 beta. When the first oxygen molecule binds to the hemoglobin, it undergoes positive cooperativity. That's high yield. Now, tell me, what do we mean by positive cooperativity in simple terms?
What do we mean by what? I'm sorry.
What do we mean by positive cooperativity?
As soon as one oxygen binds, that raises the affinity for another oxygen to bind, so it positively increases that.
Yes. Because the first oxygen comes in, the second oxygen, it's much easier to bind, and then the third, and then the fourth. So you have the moiety, your oxygen moiety will bind increasingly faster if that first oxygen binds to your hemoglobin. Hemoglobin, this is an oxidized form of hemoglobin. It does not bind oxygen as readily as Fe2+. So this one is, the oxidized form is ferric. Normally, you should have ferrous, right? So what happens if it's in a ferric form? It leads to tissue hypoxia. So you have decrease in O2 sat and oxygen content. They're going to put in the vignette cyanosis and chocolate-colored blood. What can you give? High-yield nitrites and methylene blue. You could also give that, or an antioxidant, for example, vitamin C. Okay, this is high yield, guys. Put a star here. Hemoglobin, beta thalassemia, alpha thalassemia, sickle cell, and hemoglobin C. Alpha thalassemia, what's wrong in alpha thalassemia?
We have a deletion in the alpha chains.
Alpha chain, excellent. So look here on the alpha trait, HbA and HbA2 and HbF, they're all decreased, right? What do you have is HbH for the trait. If it's an HbH disease, an intermediate form of alpha thalassemia, everything is decreased except for HbH. That's why it's called HbH disease. If it's HB Bart's, everything is absent except for the HB Bart's. So in the vignette, okay? In the vignette, if everything is decreased except for HbH, it is alpha thalassemia intermediate. This one, right? The HbH disease. If everything is absent except for the HB Bart's, then it is alpha thalassemia major or HB Bart's disease. Right. Beta thalassemia, beta globin chain. Major beta thalassemia or Cooley's anemia, HbA is absent. HbA2 and HbF is increased, right? In the minor trait, they're a little bit increased, right? HbA2 and HbF. Why? is HbA absent in beta thalassemia? Because you don't have a beta globin chain. And HbA, you need a beta globin chain to produce it. So the only hemoglobin that is increased is those hemoglobin that doesn't have the beta chain, which is HbA2, you have alpha and delta chain, and HbF, alpha and gamma chain. That's the reason why in beta thalassemia major you don't have HbA, because HbA consists of beta chain, and you don't have that in beta thalassemia. Sickle cell disease, HbA, HbA2 absent, you have an increase in HbF, 2 alphas and 2 deltas. What can you give if someone is in sickle cell crisis? Give me a drug. That can help you in the sickling process. Aside from, of course, we're going to give IV, we're going to give oxygen, we're going to give morphine. Give me a drug.
Hydroxyurea.
Good job, high yield. Don't forget hydroxyurea. You can have sickling, right? During sickling crisis, you can give hydroxyurea. And hemoglobin C, middle yield, I guess. So HBC disease. So everything is absent except for hemoglobin C. I think this is due to lysine defect, right? For hemoglobin C, if I'm not mistaken. Okay, so for this one, for your hemoglobinopathies, know the definition of the thalassemias, a different kind, know how to differentiate them, specifically the lab values. What can you see? The specific hemoglobin that's absent, the specific hemoglobin that's increased or decreased in each of the hemoglobinopathies, because that's the only way that you can differentiate them. All right. This one, another high yield point, Bohr effect versus Haldane effect. So in peripheral tissues, we have Bohr effect. The affinity of hemoglobin for oxygen decreases as the concentration of CO2 and H plus increases. Why? Because we need to offload the oxygen to the peripheral tissues. Contrast that with what happens in the lungs with the Haldane effect. The deoxygenated hemoglobin in the lungs has a higher affinity for CO2 than oxygenated hemoglobin. Why? Because we need an uptake of CO2 there, and CO2 is transported to the lungs, where it is easily dissociated from hemoglobin and is exhaled. Peripheral tissue, Bohr effect, to offload that oxygen, and you get the CO2. In the lungs, you have the Haldane effect. The deoxygenated hemoglobin has a higher affinity for CO2 than the oxygenated hemoglobin. Why? Deoxygenated hemoglobin is present in the peripheral tissue, so you need to uptake, you need to get that CO2 there. And then it is transported to the lungs, where it's associated from hemoglobin and exhaled. This is, put a star here, the difference between Bohr effect and the Haldane effect. Know them. Another high yield point, oxygen dissociation curve for your hemoglobin and myoglobin. The difference between myoglobin and hemoglobin is a tetramer for hemes, so for oxygen molecules can attach. It is sigmoidal curve for hemoglobin for transport of oxygen. Myoglobin is only one heme monomeric, so it only binds to one oxygen molecule. However, it's a hyperbolic curve with your myoglobin. Very high affinity for oxygen. Function is storage of O2 in your muscles.
Sorry to interrupt you, but I definitely know the Bohr effect. Could you review what the Haldane effect is?
The Haldane effect is the CO2 affinity of hemoglobin is inversely proportional to the oxygenation of hemoglobin. So when hemoglobin is oxygenated, for example, in the lungs, that oxygenated hemoglobin, it has a decreased affinity for CO2. So the CO2 that is bound to that hemoglobin is released in the pulmonary arteries to diffuse into the alveoli. So the hemoglobin, it releases that bound CO2 and also H plus. That's why CO2 is exhaled in your lungs. So that's the Haldane effect. We're good?
Thank you.
No worries.
Yeah.
Again, another high yield is this curve here. So this is from first aid. What happens if it's right shifted or left shifted? So right shift, ACE bats, decrease in pH, exercise, 2-3 ppg, high altitude, and then increase in temperature. There's another one here. We'll talk about that one. Did you talk about glycolysis? Or no?
Yeah, we went through all the mechanisms and stuff. We did the biochem of it.
Okay. So this is more of this in term 2. Know the enzyme that's involved. Rate limiting step of glycolysis. What's the rate limiting step?
Fructose 1,6-bisphosphate.
Rate limiting step of glycolysis, PFK1, phosphofructokinase 1. That's your limiting step. Did they talk to you about the difference between hexokinase and glucokinase? Or no?
Like in relation to their location?
In relation to which one is inducible by insulin? Or not yet?
No, I don't think so.
Okay, so that's for next term then.
Wouldn't that be glucokinase?
Yes, of course. So PFK1, that's a rate limiting step. How many ATP you're going to invest?
2.
2. What can you get out?
Technically, you get 4 out, but you use 2, so your overall is 2 made.
And that is 2. Know the regulation. Like, for example, PFK, well, I think it's for next term. I'm confusing this with for next term. Did you talk about citrate? Did you talk about aldolase? No, not yet.
We did, but I don't really remember too much of it.
So if I increase citrate, what happens to PFK? Increase or decrease?
No, I think we focused on the 2,3 BPG because she was trying to do what was related to hemoglobin.
Yes. Okay. Okay. Sorry about that. So this one is probably much more on next term. A slide for that. So know the dissociation curve. That's high yield. Cyanide poisoning and carbon monoxide poisoning. Did you talk about this or not yet?
Yeah, we did. Carbon monoxide is the like 25,000 more affinity, and then once you bind carbon monoxide, you can't release any oxygens, and also you can't bind anything either.
Hyperbaric oxygen, exactly. Headache, dizziness, all of those good stuff. So this is just like a summary slide of everything from first aid, like what happens in oxygen deprivation, the different zones, VQ ratio on different zones, the mismatch, what happens in the tissue here, your Haldane effect, all of those good stuff. So carbon dioxide transport, it transported in the lungs, high yield via bicarb, formed bicarb. Some of them 21% via HbCO2, a CO2 that's bound to hemoglobin, and sometimes least is dissolved, but mostly via HCO3. You need carbonic anhydrase to convert your CO2 to HCO3 in order for the carbon dioxide to be transported in the blood. High yield, what happens in response to high altitude? You have decrease in atmospheric oxygen, decrease in partial pressure, the AO2 of oxygen. That's why you hyperventilate. If I am hyperventilating, what happens to the pressure of carbon dioxide? It decreases. So I have respiratory alkalosis. So it can induce altitude sickness. So what happens in my body? I am hyperventilating. I am in respiratory alkalosis. I'm having altitude sickness. So the body will try to increase hematocrit and hemoglobin via increasing EPO, erythropoietin. Athletes, like runners, cyclists, they abuse EPO. Think of Lance Armstrong. Increased 2,3 BPG, it binds to hemoglobin, causes a rightward shift of the ODC so that hemoglobin releases more oxygen. So, of course, increase the mitochondria. You need the energy. Also, renal excretion of bicarb. You're in respiratory alkalosis. Too much HCO3. That's why the urinary system is excreting that HCO3 to compensate for your respiratory alkalosis. Don't forget that if you're you're living in high altitude, you can have chronic hypoxic pulmonary vasoconstriction, which can result in pulmonary hypertension and right ventricular heart failure. Know the physiology. Let's start here. When you go to high altitude, know the body responses to high altitude and why is the body doing that. Another high yield, but let's start here. Response to exercise, what happens? Increased CO2 production, increased O2 consumption, you increase the ventilation rate, leaking ratio increases, you increase the pulmonary blood flow, you decrease the pH. No change in partial pressure of alveolar. PaCO2, right, in the lungs. So basically, this is a DLA. Everything is good. So when you exercise, you're doing good to your body. Just saying. All right. So can we have like